Hmm.
Good afternoon, everyone. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please enter your questions in the chat after the presentation, and please answer a brief survey that will be sent to you immediately after the rounds. This will let us know that you were present here today. And finally, our speaker from our own division of cardiology, Dr. Atul Verma, who is our McGill and MUHC Divisional Director of Cardiology. He is a cardiologist specialized in electrophysiology. His particular interest is in interventional solutions for treating arrhythmias, such as pacemaker or defibrillator implantation. He is currently involved in several clinical trials on new technologies and techniques for catheter ablation of AFib and ventricular tachycardia. And I will point out one of these was recently published with him as first author in the New England Journal of Medicine, a landmark trial. He also works in a translational lab where they evaluate new ablation techniques such as pulse field ablation, ultra-low temperature, cryoablation, and needle ablation. It is a great pleasure to have you here today. Atul, go right ahead. Thank you.
Great. Well, thank you very much, Nadia. Maybe just as a quick check, can everyone see my slides and can everyone hear me?
Okay.
Yeah, all good? Okay, perfect. So today I'm going to be talking about antithrombotic therapy after successful catheter ablation of atrial fibrillation. I'll start off by saying that this is one of the most common questions that we get asked as electrophysiologists. So we'll ablate the atrial fibrillation. The atrial fibrillation will now be gone or pretty much gone. And the patients immediately upon hearing this want to come off their blood thinners because they hate taking blood thinners. And so this is not only a very important question for patients, it's also very important for us doctors because up until this time, and I will move to the next slide here, up until this time, our guidelines have basically been very conservative. And they basically say that if you've had an AF ablation, continuation of systemic anticoagulation more than 2 months post-ablation should be based on the patient's stroke risk profile and not on the perceived success or failure of the ablation procedure. So in a nutshell, what this is saying is don't go with whether the procedure is successful or not, go by the patient's CHADS-VAS score. So this is very conservative, and you can see that these guidelines were basically based on expert opinion, which is what the EO stands for. So even though it's a class 1 recommendation, the level of evidence is just expert opinion. There were no trials on which to base this. And why did they say that? Well, we know that late atrial fibrillation post-ablation can happen. And this is data from my previous hospital where we had a huge database of patients that we had been following for years and years. And we looked at the incidence of late atrial fibrillation recurrence happening after an ablation procedure. And you can see that the vast majority of recurrences happen within the first year. So usually within a year, we'll know whether the ablation was successful or not and decide whether we're going to do another ablation or not. In the second year, there are a few recurrences that happen, but once you're out to the third, fourth, fifth, and beyond, the rate of recurrence is actually very, very low, but it still happens. So this is why the guidelines were conservative. I'll skip over this slide. The other reason why the guidelines were conservative is because we have known for quite a number of years that after ablation, even if a patient is still having recurrent atrial fibrillation, for some reason, these AF recurrences seem to be less symptomatic. And there's a number of potential reasons for this. The episodes may be shorter, they may be slower, so they're less likely to be picked up by the patient. But we know that the proportion of asymptomatic episodes of atrial fibrillation increases after ablation. We also know from some data, although I'll explain later why this data is limited, that patients don't necessarily need to be in atrial fibrillation at the time of their stroke. So the red line in the middle of the screen represents the time of the stroke, and these black and gray bars represent whether the patient was in atrial fibrillation or not. And you can see here that in some cases, the patient is clearly in atrial fibrillation when they have their stroke, but there are other cases where the patient hasn't had any AFib in the weeks and months before the stroke and even after the stroke, and yet they still have a stroke. We also know from older data that as little as 6 minutes of atrial fibrillation can increase the risk of stroke by 2.5 times. So when you put all this data together, it seems like it's right to be conservative because, patients can still have ongoing episodes of AFib. Those episodes may be less symptomatic. And according to older studies, as much as 6 minutes of atrial fibrillation may be enough to increase the risk of stroke. However, when you start to dive into the details a little bit more, it turns out in the ASSERT trial, if you divide the patients by quartile, you realize that the patients who were getting the strokes were the patients who were having much more than 6 minutes of atrial fibrillation. In fact, they then published this sub-study of their trial where they showed that your stroke risk, if you had 6 minutes to 6 hours or 6 hours to 24 hours of AFib, really didn't change a whole lot. And it was really only the patients who were having more than 24 hours of AFib that were really driving all of that stroke risk. The other piece of evidence here is that even though there are Kaplan-Meier curves from many, many studies suggesting that AF ablation is not a totally successful procedure with about 50% success in this trial that was now published in 2019, remember that the endpoints for all of these trials was freedom from atrial fibrillation longer than 30 seconds. And I think the field did itself a great disservice by choosing that endpoint because effectively that meant we needed to cure atrial fibrillation completely. But if you take a look at this data, which suggests that AF ablation is not very effective, look at it in terms of burden. So all of these patients had implanted devices which could measure AF burden in real time. And you can see that that 50% success rate actually correlated to a 99% or higher reduction in AF burden. So yes, the patient may be considered a failure because they had 31 seconds of atrial fibrillation, but are they really having a significant enough burden that we need to care about it? There's also more, contemporary data that basically contradicts the old teaching that the risk of stroke with paroxysmal atrial fibrillation is exactly the same as the risk of stroke with persistent atrial fibrillation. So we used to think all atrial fibrillation has exactly the same risk of stroke. Doesn't matter if it's paroxysmal or persistent. But actually, it would appear from more contemporary trials that, in fact, persistent atrial fibrillation does have a higher risk of stroke than paroxysmal atrial fibrillation, again, supporting the idea that the amount of atrial fibrillation is important when you're thinking about the risk of stroke. I'm now coming back to this data, which suggested that you don't need to be in atrial fibrillation at the time of your stroke. And I think the biggest limitation of data like this is that the underlying mechanism of these strokes is really unknown. Most of these strokes may have been due to non-cardioembolic events like lacunar strokes or carotid strokes, things that have nothing to do with atrial fibrillation. And remember, only about 20 to 30% of strokes in a broad population are actually due to cardioembolism. So all of these strokes were not necessarily cardioembolic strokes secondary to atrial fibrillation. And as it turns out, there is a strong temporal relationship between the occurrence of AF and stroke, such that in this study by Tarakia and group, they showed that the risk of stroke was actually highest within the first 5 days after a prolonged episode of atrial fibrillation. So the idea that atrial fibrillation occurrence and stroke are not related is not exactly true. So historically, there have been a bunch of single center or multi-center cohort studies performed. So these were not randomized studies, but they were cohort studies where they basically followed patients and they tried discontinuing the anticoagulation in some of these patients. And overall, what you see in this right-hand column is that the overall risk of stroke in these patients generally was very low. Now, there are a couple of sub-studies which are a little bit aberrant in their results, but for the most part, if you had an ablation and you were willing to either stop the oral anticoagulation as a physician, or many of these patients just stopped it because they didn't want to take it anymore, and they were then followed, the overall risk of stroke seemed to be very low. So the meta-analysis was done of all of these cohort studies. This was done fairly recently in 2023. And here are the patients who were at high risk of thromboembolism. So they had a very high CHA2DS2-VASc score. And these are the patients at intermediate risk of thromboembolism. So they had a moderate CHA2DS2-VASc score. And here is the off anticoagulation and the on anticoagulation. And you can see here that even when it comes to the risk of thromboembolism, if anything, the off anticoagulation group seemed to have a lower risk of stroke than the on anticoagulation group. And certainly when it came to bleeding, bleeding was definitely reduced by either the presence of antiplatelet drugs or no antiplatelet drugs. Either way, the risk of bleeding was less. But of course, this is a meta-analysis of non-randomized cohort studies. And so obviously there's going to be selection bias here because the patients who came off oral anticoagulation, either because the doctor decided to stop it or the patient decided to stop it, were likely lower risk patients to begin with. So, that's why the results can look like they benefit oral anticoagulation when in fact it may have just been a selection bias of the patients who were actually stopping oral anticoagulation. We've also learned in more recent years that rhythm control is better than rate control for the prevention of stroke. So the older studies like AFFIRM and AFCHF suggested it doesn't matter whether the patient's in AF or they're rate controlled, it doesn't matter. Their risk of stroke is the same. But in fact, when you look at it in more contemporary data, and this is probably the best trial of the bunch, what they showed is when it comes to hard outcomes like mortality, major adverse cardiac events, or stroke, early rhythm control, maintenance of sinus rhythm, is actually beneficial over rate control. And not all of these patients got ablation. In fact, only 20% of these patients got ablation. Most of them were on antiarrhythmic drugs. And yet there was still a benefit. In fact, the trial was stopped early because of the magnitude of the benefit in favor of early rhythm control. We also know there have been a bunch of studies published in the last couple of years on subclinical atrial fibrillation. So remember, I talked about the ASSERT trial saying that as little as 6 minutes of atrial fibrillation could increase your risk of stroke. So there have now been a couple of trials which have randomized these patients with brief episodes of AFib to either oral anticoagulation or no oral anticoagulation. And in this study, the NOAA study, what they found was that there was no benefit of anticoagulating the patients with lower levels of atrial fibrillation. And furthermore, there was increased major bleeding, of course. In another trial called the Artesia trial, they compared aspirin to apixaban. And what they found for these brief episodes of atrial fibrillation was that, in fact, apixaban did have a statistically significant benefit in terms of stroke over aspirin, which you could argue is similar to placebo. But of course, that came at a price of more major bleeding. But when they dived into these results on a more detailed level, what they found is, in fact, all of the benefit for stroke and systemic embolism was happening in this high CHA2DS2-VASc group greater than 4. But for the lower risk groups, there did not seem to be a benefit to oral anticoagulation. So once again, you can look at the top line result here, but when you actually dive into the details, you have to realize that it was only the very high-risk patients who were actually benefiting. This is more data from a Japanese administrative claims registry. Again, more contemporary data in over 230,000 patients in Japan. And you'll see that, there were a certain number of patients who discontinued their anticoagulation within the first year after their ablation. And most of those patients who discontinued had a lower CHA2DS2 score. But what was interesting is that whether the patient had a CHA2DS2 score of less than 1, there was no benefit to continuing anticoagulation. And you could say, well, that's obvious because their CHA2DS2 score was not that high. But even in the CHA2DS2 population, there was no benefit of continuing oral anticoagulation. And it really wasn't until you got into the very high-risk patients, CHA2DS2-3 or more, that you started to see a benefit in stopping in continuing oral anticoagulation. This is another retrospective cohort study, smaller group of patients, but published just within the last year, 1,800 patients. Again, they looked at thromboembolic events in the patients who discontinued oral anticoagulation versus the patients who continued. They suggested that continuing oral anticoagulation meant there was lower risk of stroke. And of course, that discontinuing oral anticoagulation also meant that you had less bleeding. So the bottom line is, there's a lot of equipoise when you look at this data. And, there are some studies that are saying, well, you should continue. There are some studies that are saying you don't need to continue. There are some studies saying you need to continue, but in certain risk populations. And so that's where our trial came in, the Ocean trial. And, I need to thank all of the investigators who worked so hard to make this trial successful. This was a 10-year effort. It really was one of those babies that took a long, long time to give birth. And, we also had to deal with a COVID-19 pandemic in the midst of all this. So it really was a tremendous effort on the part of everyone. But this was basically a multi-center international prospective randomized open label blinded endpoint trial at 56 sites in 6 countries. The countries were all over the world. So we had China, we had Canada, we had European sites, we had Australia. So it really was a global study. All of the outcomes were adjudicated by a blinded independent committee. And the key really to understanding this trial is we took patients who were considered successful 1 year after their last ablation procedure. So if you think back to that data that I showed you before, where most of the recurrences, 60% of them happen within the first year, we wanted to get rid of all of those patients. We wanted to allow patients to have their first ablation. If they needed another ablation, they could have another ablation. We didn't care how many ablations the patients had, as long as they were at least 1 year quiet after their last ablation procedure. And we intentionally had a very practical monitoring protocol because, if we had put implantable loop recorders in all of these patients, we knew that no one would be able to practically implement this type of strategy. So we kept it very simple: 24-hour Holter in the first 6 months, 24-hour Holter in the next 6 months, 48-hour Holter before enrollment. And all patients had to be a CHA2DS2-VASc score of greater than or equal to 1, or greater than and equal to 2 in the case of female sex or vascular disease. I'm not going to talk about exclusion criteria, only to say that if a patient had a disabling stroke within a year or any stroke within 14 days, they were excluded. So we randomized the patients either to rivaroxaban, a dose of 15 milligrams, or aspirin, 70 to 120, depending on the jurisdiction. Why did we choose 15 milligrams? Well, we wanted a drug that basically was not going to cause a lot of bleeding, but we knew that rivaroxaban had an 80 to 90% pharmacokinetic overlap to 20 milligrams. And there's never been any study showing an increased risk of stroke with this dose, even in normal patients. So we were very comfortable going down to 15. And there were actually a lot of trials at the time using the 15 milligram dose. We chose aspirin because we did not at the time feel comfortable leaving these patients on nothing. However, over time, the guidelines soured on aspirin for primary prevention, for AFib. All the guidelines now are very anti-aspirin, but, I think that's a little overdone anyway. But bottom line is we used aspirin. All patients underwent a brain MRI at baseline, 1 year and 3 years. So not only were we looking at clinical strokes, but we wanted to understand what was happening in the brains of these patients. Because of the COVID-19 pandemic, we removed the requirement for the 1 year MRI. And the University of Calgary is a world famous core lab for brain imaging. And so we used them. To prevent crossovers, we protocol defined what should be done for patients who needed a cardioversion, acute coronary intervention, or surgical procedure. And as long as the investigators followed those guidelines, then these patients were not considered crossovers. However, if the patient needed a repeat AF ablation, they were exited from the study. And the follow-up was 3 years. So in terms of the primary efficacy outcome, it was a composite of stroke, systemic embolism, and covert embolic stroke defined as an infarct greater than 15 millimeters on the 3-year MRI. So why did we add that? Well, we added that for several reasons. One is that there's a growing literature in the neurological field that covert embolic strokes are important and that they may occur in a 1-to-1 or 2-to-1 ratio over clinical strokes. And so we wanted more events so that we could reduce our sample size. And we also knew that, we would have a lot of very detailed data on these patients by including the MRI endpoint. The primary safety outcome was fatal and major bleeding as defined by the International Society of Thrombosis and Hemostasis. We planned a sample size of 1,572 patients based on what we thought was a very conservative rate of the primary outcome of 3.5% per year. We tried to be as conservative as possible. However, in 2022, the DSMB recommended stopping the trial because of the high likelihood that we would not demonstrate a benefit for rivaroxaban. Investigators were actually not made aware of the interim results. They were told that the trial was stopping, but that all randomized patients should complete their follow-up in their randomized group. So we ended up enrolling only 1,284 patients. The investigators were incredible. Despite a pandemic, only 4 patients were lost to follow-up in each arm. 5.5% of patients exited because of a repeat ablation. And if you can believe this, 97.4% of surviving patients received their 3-year brain MRI. I mean, that's incredible compliance with the trial. So in terms of the overall population, I'm not going to bore you with all these details, but a few important points to point out. Patients on average were about 16 months after their last ablation. About 2/3 had paroxysmal atrial fibrillation, 1/3 had persistent. And the mean CHA2DS2-VASc score was 2.2. And you can see that we had pretty good representation of CHA2DS2-VASc 1, 2, and 3. But once we got to CHA2DS2-VASc 4 or more, our representation certainly dropped off. So here is the primary endpoint of the trial. So the primary composite endpoint, which was stroke, systemic embolism, or covert stroke, happened in only 5 patients in the rivaroxaban group and only 9 patients in the aspirin group. So if you look at this as an annualized risk, the risk of the composite was only 0.3% for rivaroxaban and 0.66% for aspirin. And if you look at stroke or systemic embolism and you remove the MRI endpoint, again, the risk was 0.3% for rivaroxaban, 0.6% for aspirin. These are very, very, very low risks of stroke. We usually think about anticoagulating patients when their risk is 1 to 1.5% per year, and both arms were substantially below that. What's also very interesting is that 96% of patients had no new infarct of any size on their MRI at 3 years. I mean, that's a pretty bold finding. So looking just at stroke and systemic embolism, this is the Kaplan-Meier curve that we included. There was basically no statistically significant difference between aspirin and rivaroxaban. And even when you look at the cumulative incidence on aspirin after the 3-year follow-up, I mean, it's very low. It's very, very low. This is a blown up scale, but if you look at the scale on a 100% scale, you cannot even see the lines on this scale. Fatal and major bleeding did not differ substantially between rivaroxaban and aspirin. But overall, the bleeding risks were very, very low. However, when it came to clinically relevant non-major bleeding or minor bleeding, certainly rivaroxaban was a disadvantage for these patients. And if we look at the number needed to treat, the number needed to treat one stroke or systemic embolism in this trial was 333. But the number needed to harm, and this is fatal or major bleeds. So these are not minor bleeds. These are like ISTH major bleeds. And I put the definition here so you can understand that, is 111. So in other words, for every stroke that you're going to prevent, you're going to create 3 major bleeds. There was another trial published called the Alone AF trial, which was published in JAMA. It actually came out literally 3 months before our trial. It was presented at ESC. We presented at AHA. So Alone had a similar design. They took patients 1 year post-ablation, but they randomized them either to apixaban or placebo. So they did not have aspirin in their trial. And we did a meta-analysis of these 2 trials, and overall we see that for clinical stroke, ischemic stroke, yeah, there were large confidence intervals, but no statistically significant difference between continuing anticoagulation or discontinuing. We also tried to look at the CHA2DS2-VASc 4 or higher group because we had such little representation in that group, but so did Alone AF. So in total, there were only really about 116 patients. But in these 116 patients, there were basically no major events. So, the overall risk in this group seemed to be low. So what's our interpretation of the trial? Well, this is our interpretation of the trial. This is coming out in Circulation. They invited us to publish an opinion piece. And so we say that if a patient is at least 1 year post-successful ablation or ablations, and they have a CHA2DS2-VASc score of 1 to 3 with no history of recent stroke, you can choose to discontinue the anticoagulation. If they've had a history of stroke within the last year, you probably want to consider ongoing anticoagulation. If they have a CHA2DS2-VASc score of 4 or more, probably consider ongoing anticoagulation. And you would only put in a left atrial appendage occlusion device if they have an absolute contraindication to anticoagulation. In the US, it's becoming vogue to do an AF ablation and put an occluder device in at the same time. I don't believe that the evidence supports this. There was a trial called the Option trial, which showed that, yes, this is technically feasible, but they failed to demonstrate any clinical benefit to that strategy. So I certainly wouldn't recommend it. The Closure AF trial is coming soon to the New England Journal. This was a very informative trial because they looked at including the appendage, even in the highest risk patients, the patients who really you would have thought deserved an occlusion device. And yet they found that these patients died, did not have less bleeding, and had complications as a result of this intervention. So you should definitely read that trial. So in conclusion, in our trial, rivaroxaban did not decrease the rate of a composite of stroke, systemic embolism, and covert embolic stroke compared to aspirin. The overall annualized rate of stroke systemic embolism is very low after successful ablation, regardless of which therapy you were on, and it falls below the traditional threshold for anticoagulation that we normally think of. So with that, I'm going to stop. I intentionally stopped a little bit early to answer any questions that people may have. And also, if there aren't very many questions, to give you back a little bit of time in your day.
Thank you. Fantastic. Thank you so much, Atul. Terrific. Congratulations on your study. Terrific. That's quite the feat. 10 years, 6 countries, 56 sites. Congratulations on leading that. Any questions from the audience? Okay, I'm going to start with a question here. So, Atul, you mentioned on this that to be enrolled in the study, you had to do, 2 times 24-hour Holters and 1 time 48 hours Holter.
Yeah.
From what I'm seeing from your conclusions, you're not necessarily recommending that in all comers.
Well, I think, we chose to do a fairly minimalist monitoring regimen. If you look at different countries, they're monitoring in most places a lot more than that. In the US, they're putting in a lot of implantable monitors. In Europe, they do a lot of patch monitors, that stay on for 7 days. In Canada, other than Quebec, people do frequent Holters. Quebec's a bit of an outlier in terms of our access to monitoring and Holters and patch monitors and all that sort of stuff. So, we tried to come up with something that most jurisdictions in the world could realistically do and could realistically replicate.
Okay. Mark, thank you. Thank you, Atul. Mark, your hand is up.
Yeah, thanks, Atul. Brilliant work and congratulations on a fantastic practice-changing study. I'm going to ask you an unfair question, and actually, I'm going to start with a comment. My patients actually like anticoagulants, Atul, so I'm surprised that your patients are telling you that they don't like anticoagulants.
Yeah, I mean, it's probably a difference in our practices for sure. But AF ablation patients hate oral anticoagulation. They just hate it.
So my unfair question is, there are recent trials in the venous thrombosis literature that show that low dose apixaban specifically, but also low dose rivaroxaban, but apixaban have lower major bleeding risks and the bleeding risks are basically comparable to aspirin. Do you think you would have had different results, or you come to a different conclusion if you'd used a low dose DOAC instead? I know it's not a fair question, but I'm going to ask it.
Well, no, I mean, in a way, we did use a low dose DOAC because we used the lower dose of rivaroxaban, although 15 milligrams arguably is therapeutically equivalent to 20. By low dose, you may be meaning 2.5 or 5 BID of rivaroxaban or 2.5 BID of apixaban.
Yeah.
Yeah, I think, at the end of the day, we probably would have seen similarly low event rates because we do have an aspirin arm. And, the aspirin arm, arguably for stroke prevention, which is arterial on the arterial side rather than on the venous side, 2.5 BID or 5 BID of rivaroxaban probably wouldn't have been enough. But at the end of the day, we would have seen a similarly low event rate. I mean, whether it was 0.3 or 0.4, 0.5% per year, it definitely wouldn't be any worse than aspirin. And if anything, it might have been slightly better than aspirin. So, I think we would have seen something in the 0.4 to 0.5% per year range.
Thank you.
George, do you want to unmute? You have a question/comment, George?
Sure. Thanks, Atul. Your patients were enrolled a year after the AFib ablation.
At least a year. At least a year. Yeah.
So are you in your comments and your final summary? So patients who are successfully ablated, the point is you still put them on anticoagulation for a year?
Yes, that's right. So, what I explain to patients is, I mean, if their CHADS VAS score is 0, or if they're 1 because they're female, then after the first couple of months of anticoagulation, once the ablation settles down, they don't need to continue on oral anticoagulation because we wouldn't have anticoagulated them anyway, even if they had atrial fibrillation. So the zeros and the ones, because of female sex, they don't need to be anticoagulated. But everyone else, I will anticoagulate for a year. And I will tell them, we will not have the discussion about stopping this until you're at least a year post. And that's when we can have the discussion.
In your first slide, or one of the early slides, you showed the 50% recurrence in the first year.
Yes.
And then there was a 20% and then a 7% and so on.
Yeah.
So in your study, if you took them after 1 year, how many did you see? Was it similar, different in terms of recurrence?
Yeah, that's a very, very good question. So the only thing we published in the main manuscript is that 5.5% of patients got a repeat ablation over 3 years. So if you take 5.5 divided by 3, it's about 1.8 or whatever. So that means about 2% of patients had enough AFib to warrant another ablation per year, which is pretty low. It's consistent with the other data that I showed you on the earlier slides where the rates were 3 or 4%, long term. We are presenting a late-breaking trial at ERA coming up soon, looking at how many recurrences these patients had, how long the recurrences were they persistent, were they paroxysmal, what did people do, in terms of cardioversion or antiarrhythmics. So we do have that data, and we're right now putting that together for another paper. And the other little secret that we didn't really tell anybody was that in a subset of 200 patients, we actually implanted implantable monitors, which monitored for AFib 24 hours a day, 7 days a week. And so that will be yet another publication to say, if we had monitored these patients 24/7, what would we have found in these patients?
Yeah. So just as a quick corollary to that, 2% per year, do those people go back on anticoagulants?
Yeah, so that's why we exited them from the study, because we felt that in effect they were traveling back in time to another state of their disease. Now, some people have argued with us, like we shouldn't have exited them, we should have kept them in. But the problem is, by practice standards, everyone needs to be anticoagulated for at least a month before an ablation. And they need to be anticoagulated for at least 2 months post the ablation, regardless of their CHA2DS2-VASc score. Even if they have a score of 0, they need that anticoagulation. So we felt like keeping these patients in, was not really fair anymore because it was going to contaminate the results.
Okay, thanks. Congratulations.
Magdi, I don't know if your questions were answered. Your question was answered. Do you want to unmute, Magdi?
Yes, my question was answered. Thank you. And
his question was recurrent AFib after a year when you already stopped anticoagulation. What do you do when you have recurrent AFib after a year?
Yeah, it's a great question. I mean, we don't know what to do. Like how much AFib do they need? What duration of AFib? What if they only have, 6 hours of AFib? Do we restart? If they have 24 hours of AFib, do we restart? And so we're hoping to learn that from the sub-studies that I was talking about when George asked his questions, from the implantable monitors and from the recurrences, can we understand how much AFib these patients were having and what clinical actions were taken in response to those AFib recurrences?
Thank you. David Bélanger, do you want to ask your question? Is question,
Hi.
David, are you there?
Yeah, I'm there. I just wanted to just clarify when you, in practice, you consider not giving any anticoagulation or aspirin at all, because obviously you were comparing aspirin and anticoagulation, but in your summary you were mentioning potentially not giving anything.
Yeah, so Alone AF, which was the other big study, gave nothing, and we gave aspirin. And the skeptics would say that aspirin for atrial fibrillation is like a placebo that bleeds. So if you believe that aspirin is equivalent to placebo, then, and given that Alone AF was published, you could argue that not giving anything is reasonable. I personally am not that anti-aspirin. I actually still believe in aspirin in some select cases. So personally, I would stick with the ocean approach, which is I would put patients on aspirin. But any number of people could argue with me and say, oh, we want to give placebo. So I'm not gonna defend my position more than that.
The tool for you use, just to take a step back, you mentioned that even at 6 minutes of AFib, there is a risk of stroke compared to no AFib. For people who are doing Holters and you see 10 minutes of AFib and your CHA2DS is, I don't know, 2. Do we give anticoagulation?
No. So, yes, the ASSERT trial from many years ago said that. But as I showed, the risk doesn't go up until you're more than 24 hours in AFib. And in the Artesia trial, the only patients who benefited from anticoagulation with such short durations of AFib had a CHA2DS score of 4 or more. So specifically for the patient that you mentioned, I would not recommend oral anticoagulation. I wouldn't do it.
Even with a CHAD score of 4 more in 10 minutes of AFib.
So if they had a score of 4 or more in 10 minutes of AFib, yes, it would be considered. But I think you had said 2.
Yeah,
so
I said 2. I'm changing.
So then I would not do it.
Okay, David G.
Yes, hi, Dr. Verma. So, my question was, in the OCEAN trial, anyone that was on antiarrhythmic medication, sort of that continued even after the ablation?
Yeah, so we didn't necessarily exclude patients who were still on antiarrhythmics. In table 1 of the OCEAN publication, you will see what percentage of patients were still on antiarrhythmics and which antiarrhythmics. So that is included in the main publication. We also will look, when we're looking at recurrences, at the patterns of recurrence of those who stayed on antiarrhythmics versus those who did not stay on antiarrhythmics. But using antiarrhythmics post-ablation was not an exclusion. So you could have had a successful ablation, you were still on sotalol 40 BID, and that was fine.
Okay, go ahead. Mark Liskowski has a question.
Yeah, hi, Atul. Thanks for the mention.
Nadia, you muted, so I can't hear Mark.
So you guys hear them? I have the mic now.
Yeah.
I'm putting impressed at how low the event rates are post-ablation, post 1 year after ablation.
Yeah.
What do you think actually accounts for that versus a general non-ablated paroxysmal AFib population? Is it the fact that the burden of AF is much lower post-ablation, or is
That's it.
Selected AF ablation candidates, the smaller atria, no valvular heart disease, other factors that are selected to be ablation patients versus the non-ablated patients, which could have other cardiac disease?
I think it's related to burden. I think it's completely related to burden. And if if there was a CHADS-VASc, like CHADS-VASc is clearly not a good tool for risk stratification in atrial fibrillation. It's the best that we have, but it's not great. And if I think we need a CHADS-VASc burden score. So in addition to the CHADS-VASc risk, we have to have a way of quantifying the burden of atrial fibrillation in a patient. And, there's a lot of questions you can ask about that. How are you going to monitor them to calculate that burden? What's the cutoff for burden? What do we need? What do we not need? There are some trials that are looking into this. It seems like if your burden is more than 0.1 to 0.5%, that drives strokes and healthcare utilization and all the other sort of stuff. But we have not yet settled on that. So it's impossible to create a CHADS-VASc burden score today. But we're hoping that we can, the sub-study information that we're going to get from this trial will be informative to guidelines to be able to say, okay, well, this is the burden we had, and clearly we didn't see strokes.
Thank you. David Rosenblatt, you want to unmute?
I can unmute. I am not an epidemiologist, but first of all, I learned a ton, but my baseline level was low. Did you see any differences in results amongst different centers, different sample size, maybe different inter-doctor practices within a center, different countries, things like that?
No, we didn't. So our highest enrollment was actually in China, which is an East Asian population. If anything, East Asians may be more prone to intracerebral bleeding with anticoagulation. So we thought maybe there would be a signal towards more bleeding events, in that population. We are actually doing a formal Asian-focused analysis of our data at the request of the Asian investigators. They enrolled 200 of the 1,284 patients, so it's a sizable sample. But no, in our quick back of the envelope, regression analyses and post hoc analyses, we did not see any differences in geography or sites.
Atul, how good are commercially available wearables like an Apple Watch in terms of detecting if you have a patient who tells you I wear it, 24 hours a day, and I've worn it 24 hours a day for the last year, and I've never gotten any signals suggesting AFib. Is that something that's good for you, or you don't think these are reliable technologies?
No, they're very reliable, actually. I'm super happy that they're on the market. Apple Watches are, remember, they are two monitors in one. Okay, so when the Apple Watch is continuously monitoring you, it's using plethysmography. So it's using a light-based tool to look at your pulse and estimate what your pulse rate is and, figure out if you're in a regular or irregular rhythm. So that is naturally limited in its power. It is very sensitive, but it's not very specific. So if your Apple Watch truly tells you you've never had atrial fibrillation, you probably haven't, because it will detect and pick up premature atrial beats, premature ventricular beats, and call them possible atrial fibrillation. So it's very sensitive, not very specific. So if you don't have it, you don't have it. If it says you have it, you need to confirm. And the second type of device on an Apple Watch is a device where you can actually put your thumb on the wristband and do an ECG to actually confirm the rhythm that you're having. So when it says possible atrial fibrillation, you can do a strip and you can actually check. Cardiomobile is the other device. Obviously, it's not a continuous monitor. Patients can use it whenever they feel symptoms, but the quality of the ECG that you get is excellent. You can make a diagnosis very, very accurately from either of these devices.
Fantastic. Is any other questions in the room or on the chat? Otherwise, I'm going to ask you one last question. Atul, how much AFib is asymptomatic?
How much is asymptomatic? Well, if you believe the study we published, almost 12 years ago now, so keep in mind that technologies and ablation outcomes have gotten a lot better in the last 12 years, then up to 30% of all atrial fibrillation episodes post-ablation will be asymptomatic.
But forget the ablation. I'm talking all comers. People are walking around. They have zero symptoms. How many
I see.
at the same time or have AFib? If we have 100 people on the call, how many have AFib?
Yeah, I think, so there are, of course, some patients who have truly asymptomatic atrial fibrillation, but I think that number is a lot lower than we think. Patients will present in AFib with all kinds of symptoms: fatigue, exercise intolerance, shortness of breath, chest discomfort, et cetera. And it's very easy to tell that patient, well, you know what, you're old. Of course you're tired, forget about it, go home. But when you cardiovert these patients, they will tell you, geez, I feel better. I didn't know I could feel better. I just assumed I was aging and my doctor told me to forget about it. So I forgot about it. So I think there are truly asymptomatic patients where you cardiovert them, they have no idea, but that number is a lot lower than we think it is.
Fantastic. Well, thank you so much. Congratulations. Fantastic work. Congratulations on advancing not just the field, but putting in good, good things for McGill, making us look good. And thanks everyone. And thanks Atul. Have a great afternoon. Bye-bye.